Couple cases we can knock out quickly. Patient comes with itching after a bath. All 3 cell lines show increased cell counts, including hemoglobin, the platelets, and the leukocytes. The EPO levels are low. There's a JAK2 mutation that's present. Your diagnosis is Polycythemia vera. Some things you may not know. On exam, they will present with facial plethora, which is a ruddy cyanosis, a purple bluish coloration to their face because of the increased blood cell count. They'll also have splenomegaly. Common complications for this disorder is that the blood being more viscous increases the risk for thrombosis, which can cause a condition whose hallmark is hepatic venous outflow obstruction secondary to a thrombosis. And that condition is Budd-Chiari syndrome, which presents with abdominal pain, ascites, and you diagnose it with ultrasound. The mainstay treatment for polycythemia vera is phlebotomy. Polycythemia vera is a primary myeloproliferative disorder, which means the EPO is going to be low. For secondary myeloproliferative disorders, the EPO will be high. For example, a patient who has a 60-pack year history of smoking presents to you after being exposed to a space heater for 24 hours, has headaches, dizziness, nausea, and polycythemia, and your diagnosis will be carbon monoxide poisoning, specifically chronic carbon monoxide poisoning. The EPO levels are high because EPO responds to tissue hypoxia. When carbon monoxide binds to hemoglobin, it creates carboxyhemoglobin, and it holds on tightly to that oxygen, making the tissues hypoxic. You can thus diagnose carbon monoxide poisoning with an arterial blood gas to measure carboxyhemoglobin levels, and you treat with high flow 100% oxygen. Next case. So let's say a 20-year-old patient comes in with episodes of excruciating pain in his legs and stomach. He was exposed to severe dehydration and low oxygen levels from recently running in Colorado. His spleen is infarcted and is non-palpable. Your diagnosis will be sickle cell anemia. So for management of sickle cell anemia, you want to make sure to vaccinate when you're young for encapsulated organisms. You also want to give prophylactic antibiotics, specifically penicillin, until the age of 5. And the medication of choice is going to be hydroxyurea. Now, hydroxyurea inhibits ribonucleotide reductase and increases fetal hemoglobin levels. For acute pain crises, you're going to want to make sure to hydrate your patients, give them opioids, and consider transfusions. Some common complications of this condition are bone infarctions, avascular necrosis, osteomyelitis, which will be caused by salmonella, painless hematuria, which will be caused by renal papillary necrosis, and if they do have nephrotic syndrome, your cause will be focal segmental glomerulosclerosis. Because these patients have recurrent transfusions, some complications of that are going to be secondary hemochromatosis as well as delayed hemolytic transfusion reactions. Delayed hemolytic transfusion reactions, remember, are an immune reaction, so they cause a hemolytic anemia and a new positive Coombs test. So beforehand, the Coombs test will be negative, and after they have this transfusion reaction, it will be positive.